My name is Maxine Chen, and I am the Marketing Liaison for Discovery Biology Services at JennScript. I will start today's webinar by providing an overview of JennScript, followed by an introduction of Dr. Kenneth Jeong, who will present today's webinar. If you have any questions during this presentation, you can submit them by typing them in the questions field that should be showing on your screen right now. Dr. Jeong will do his best to answer some questions at the end of the presentation. In addition, this archived webinar and links or downloads of any of the associated materials presented today will be posted. Also, you'll receive a brief survey immediately following this webinar. I ask that you please consider filling it out, as your feedback is an invaluable resource for us in improving our services to you. A little information about JennScript. JennScript was founded in 2002 as a provider of gene synthesis. Since then, we have grown to offer our customers quality bioreagent services such as gene synthesis, peptide, protein services, antibody services, and catalog products. And since 2009, JennScript has become a one-stop service, providing customers with full drug discovery capabilities as well. JennScript is cited in over 9,000 peer-reviewed publications where our services and products have helped move research forward. And now I will introduce Dr. Kenneth Jeong, who is the Associate Director of In Vivo Pharmacology at JennScript. Dr. Jeong is a tumor immunologist with over 10 years research experience in the field of tumor microenvironments with 19 peer-reviewed publications. Bringing his experience in animal model development and immunology to JennScript, he leads the development of fibrotic disease models and tumor models. Prior to joining JennScript, Dr. Jeong was a research fellow at the City of Hope Comprehensive Cancer Center in Los Angeles, California. His research interests include immunological regulation of tumor metastasis by STAT3 and targeting STAT3 for cancer therapy. Dr. Jeong received his PhD degree from Nanjing University in China. And without further ado, I will turn the presentation over to Kenneth.
Well, thank you for the introduction, Maxine. Okay. So good morning, everyone. Thank you for taking time to attend this webinar on new targets and model development of fibrotic diseases. In my talk today, I will first generally introduce the background of fibrosis with brief mechanism in several fibrotic diseases. And then based on the mechanism, we will talk about anti-fibrotic therapeutic targets and corresponding agents. And following that, I would like to introduce available fibrotic disease models at JennScript and show validation data for selected models. So our organs are composed of two major parts, parenchyma and interstitium. Parenchyma is the part that takes charge of the major function of the organ, while interstitium is supportive. The orchestration of parenchyma and interstitium is critical for the normal function of an organ. Fibrotic diseases are the replacement of organ parenchyma by interstitium, that is, excessive extracellular matrix deposit during chronic injury, which progressively leads to impair or loss of organ function. As shown in the image on the right, epithelial cell injury initiates the development of fibrosis. And this excessive ECM expression is mainly produced by a type of cells called myofibroblasts. Major organs related to fibrosis are the liver, the lung, and the kidney. Here is a chart that I generated myself by searching for several keywords on PubMed. Shown is the numbers of publications indexed by PubMed each year. And as we can see, in recent years, there is a sharp increase in the research interest in various fibrotic diseases, and particularly liver and lung fibrosis. And this is mainly due to the huge unmet clinical need for anti-fibrosis therapeutics. And next, I will introduce several fibrotic diseases with emphasis on liver fibrosis. Liver fibrosis is a reversible wound healing response characterized by the accumulation of ECM following liver injury. Chronic injury and inflammation leads to progressive substitution of liver parenchyma by scar tissue, or called fibrosis, and finally end-stage liver disease, or cirrhosis. Liver fibrosis can be induced by many causes, such as HBV/HCV infection, alcohol abuse, non-alcoholic steatohepatitis, or NASH, chronic cholestasis disorders, including primary biliary cirrhosis, and autoimmune hepatitis. Currently, there is no drug approved for the treatment of liver fibrosis. And recently, in early 2015, obeticholic acid, a farnesoid X receptor agonist, received breakthrough therapy designation from US FDA for the treatment of NASH with fibrosis. As discussed, there are many causes that can induce liver fibrosis. The injury of hepatocytes, which is a type of epithelial cells, induces liver inflammation and activates hepatic stellate cells to differentiate into alpha SMA positive, contractile myofibroblasts, which is the major producer of collagen and other ECM proteins to form fibrosis. If the injury persists, liver fibrosis will progress to cirrhosis and finally primary hepatocellular carcinoma. Major cellular events in fibrosis development include the following ones. The initial event is hepatocyte injury and release of reactive oxygen species, ROS, and apoptotic body S. The substances released will elicitate the second major event, the activation of immune subset cells and hepatic stellate cells, HSCs, as well as their crosstalk. Immune infiltration and activated Kupffer cells in particular secrete various types of regulatory molecules, such as nitrogen monoxide, ROS, TGF-beta1, PDGF, etc., and some chemotactic molecules. And the molecules, together with those from injured hepatocytes, induce hepatic stellate cell activation. The activated HSCs will proliferate and then further transdifferentiate into myofibroblasts. Myofibroblasts express excessive ECM proteins in the space of DISA, which is the space in between hepatocyte and blood vessels, to block substance exchange between hepatocyte and blood flow. There are many cytokines and chemokines involved in the development of fibrosis, but a few are critical ones. TGF-beta1, secreted by Kupffer cells and activated HSCs, is the key mediator of fibrogenesis. TGF-beta1 enhances the transition of HSC into myofibroblasts and stimulates the synthesis of ECM proteins and overexpression of TIMPs. And the second critical molecules participate in the progress is PDGF, which is secreted mainly by Kupffer cells. And PDGF is the predominant mitogen of activated HSCs. Also, as mentioned in the last slide, Kupffer cells, which is the resident macrophages in liver, are the major source of many regulatory molecules. MCP1 or CCL2 recruits monocytes to injured liver tissue, and therefore is also an important player to regulate the disease progression. In addition to transdifferentiation from activated HSCs as the primary pathway, there are also several other resources of myofibroblasts in liver fibrosis. Myofibroblasts can derive from portal fibroblasts. This contribution is especially important in biliary diseases, such as cholestasis and primary biliary cirrhosis. And circulating fibrocytes can also be recruited to the injury site to contribute to the myofibroblast population. Also, epithelial cells, such as hepatocytes and cholangiocytes, can undergo epithelial to mesenchymal transition to become myofibroblasts. During chronic liver injury, bone marrow-derived cells may also supply the myofibroblast population, although this contribution may be limited. So after discussion on liver fibrosis, we will also have a look at pulmonary and renal fibrosis. Similar with liver fibrosis, lung fibrosis is the development of excessive connective tissue between alveolar wall and capillaries in the lung, and blocking oxygen and carbon dioxide exchange between the body and the air, and irreversibly impair respiratory function. In most cases of lung fibrosis are idiopathic, which means that it is diagnosed without any known cause. The disease can also be a secondary effect of inhalation of pollutants or pathogens, cigarette smoking, connective tissue disease, infection, and certain medication and radiotherapy. In October 2014, US FDA approved pirfenidone and nintedanib for the treatment of pulmonary fibrosis. The below image is a general mechanism of lung fibrosis. Irritants induce epithelial injury and therefore activate various immune subsets, including neutrophils, macrophages, and T cells. And TGF-beta, together with other cytokines expressed by these cells, induces accumulation of myofibroblasts and increased ECM production and deposition. For renal fibrosis, it is the common endpoints of virtually all chronic kidney diseases. Renal fibrosis include glomerulosclerosis and tubulointerstitial fibrosis, and only the latter one will render renal failure. Interstitial renal fibrosis is the excessive production of ECM between microtubules and peritubular vasculature, which impairs renal function. Renal fibrosis originates from epithelial injury of tubules. The cellular crosstalk will induce parasite detachment from the endothelium. If the injury persists, immune infiltrates will be recruited to the interstitial space between epithelium and endothelium, and parasites in interstitium will transdifferentiate into myofibroblasts, then produce abundant ECM proteins. Then fibrosis is developed. By reviewing the above introduction, and we can summarize that there are a few common features shared by various fibrotic diseases: epithelial injury and dysfunction, accumulation of myofibroblasts, deposition of fibrotic ECM, inflammation and recruitment of immune infiltrates, and contribution from profibrotic macrophages. So sharing critical mechanisms, multiple fibrotic diseases may also have similar antifibrotic targets and benefit from common therapeutic strategies. TGF-beta is the critical modulator and driver of fibrotic diseases. So targeting TGF-beta expression and activation from its latent form, as well as signaling pathways, is one of the major approaches. For example, the anti-fibrotic effect of pirfenidone is at least in part by downregulation of TGF-beta expression. Antibody to integrin alpha V beta 6 blocks the activation of latent TGF-beta and also inhibits fibrosis. Angiotensin receptor blocker and angiotensin converting enzyme inhibitors also showed anti-fibrotic effect in animal models by blocking the stimulation of TGF-beta. Also, antibody against TGF-beta 1, the predominant form of TGF-beta, may also be effective, as indicated in animal studies. Inhibitors to canonical TGF-beta signaling pathway, such as 305 for TGF type 1 receptor, ALK5, and SIS3 for SMAD3 can inhibit fibroblast transdifferentiation into myofibroblasts and reduce TGF-beta-induced ECM expression and fibrogenic cytokine production. Connective tissue growth factor, CTGF, whose expression is stimulated by TGF-beta, can in turn enhance the effect of TGF-beta to stimulate the synthesis of ECM proteins. So neutralization of CTGF can also limit the fibrogenic effect of TGF-beta. Tyrosine kinase is a non-canonical TGF-beta signaling pathways and other signaling pathways also play important roles in fibrosis. For instance, the inhibition of c-Abl activity blocks several downstream effectors required for full TGF-beta response. Blockade of PDGF signaling pathway suppresses HSC proliferation and production of ECM. So broad-spectrum tyrosine kinase inhibitors may inhibit fibrosis development by multiple mechanisms simultaneously. In addition, several transcriptional factors are highly interested targets for antifibrosis using small molecules. As an agonist of FXR, the obeticotic acid, OCA, exhibit anti-inflammatory and anti-fibrotic effects in the liver, intestine, and kidney. In addition, OCA regulates both lipid and carbohydrate metabolism, and therefore OCA demonstrated its benefit to NASH and primary biliary cirrhosis patients. For PPAR gamma, besides its role in regulating glucose and lipid metabolism, it also participates in the regulation of connective tissue hemostasis. Several pro-fibrotic factors, including TGF-beta and IL-13, suppresses the expression or activity of PPAR gamma. So its agonist can abrogate the pro-fibrotic effect of TGF-beta in vitro. It is also indicated in studies that the pro-fibrotic activity of TGF-beta is highly related to the upregulation and the transcriptional activity of AP1. So AP1 inhibitor showed anti-fibrosis effects in vitro and in vivo. Here are some more targets and corresponding agents. The recruitment of multiple types of cells to the injury site is common for fibrosis development. And this mainly includes the recruitment of circulating fibrocytes via SDF1 CXCR4 axis and the recruitment of monocytes via MCP1 CCR2 axis. Disrupting the chemotactic axis reduces the accumulation of corresponding cell population at the site of injury and inhibits fibrosis development. The immune infiltrates provides modified immunological microenvironment that facilitates fibrosis development. IL-13 helps drive macrophage to M2A polarized or pro-fibrotic phenotype and induces the proliferation and collagen production in fibroblasts. Toll-like receptor 4 signaling in fibroblasts synergizes TGF-beta signaling. So blocking important immune regulators in fibrosis, such as IL-13, IL-6, its receptor, and toll-like receptors can also inhibit fibrosis. Inhibitors of other intracellular pathways that affect fibrosis development, like JAK2, STAT3, and Wnt pathways, inhibition of the production of ROS, and blocker of endothelin-1 are also potential targets to treat fibrotic diseases. To evaluate the in vivo efficacy of antifibrotic agents, properly developed and well-characterized animal models are required. JennScript has developed multiple models covering liver, lung, and kidney fibrosis. For liver fibrosis, carbon tetrachloride intoxication-induced liver fibrosis model, and bioduct ligation, which is a cholestasis-induced liver fibrosis model, are ready for service, while TAA-induced model, an alternative for CCL4 intoxication, is still in development. For renal and pulmonary fibrosis, unilateral urothelial obstruction-induced model and bleomycin-induced model are ready for service. Selected models will be introduced in following slides. So CCL4-induced model in mouse is the most validated and well accepted liver fibrosis model by intoxication. For this model in mouse, CCL4 and olive oil mixture is injected via IP to Balbi mice. The model induces hepatocyte damage, necrosis, inflammation, and fibrosis. Available endpoints of measurement for this model include liver and body weight, serum biochemistry like ALT and AST level showing liver injury, HE staining, serous red, and Mason's trichrome staining. Both are specific stainings for connective tissue. And IHC for myofibroblasts and macrophages. Quantitative analysis of histological images, hydroxyproline assay, and RT-qPCR for alpha SMA, collagen, and TGF-beta1, etc. JennScript will be able to provide service to conduct whole slide scanning and analysis shortly. The histological images demonstrate model development at 6 weeks post-CCL4 injection. Hepatocyte damage can be observed by HE staining, while serous red staining visualizes collagen deposition in the liver. The liver has already formed bridging fibrosis as shown. Myofibroblasts and macrophages, which are the important types of cells in liver fibrosis, can be visualized by IHC staining for alpha SMA and F480 respectively. In addition to histological endpoints, elevated serum ALT and AST level, increased hydroxyproline content, and upregulated alpha SMA, collagen, and TGF-beta expression at mRNA level also indicate successful model development. Here is a case study testing the therapeutic effects of pirfenidone in this model. And treatment with pirfenidone for 4 weeks showed significant inhibition of fibrosis, as indicated by serous red staining. Quantification results are statistically significant when vehicle and treatment groups are compared. And pirfenidone downregulates transcriptional level of TGF-beta1, but not type 1 collagen, indicating that pirfenidone may affect post-transcriptional regulation of collagen in hepatic fibrosis model induced by CCL4. So next is bioduct ligation, or BDL-induced liver fibrosis in mouse and rat. This model mimics cholestasis-induced liver fibrosis, such as primary biliary cirrhosis and primary sclerosing cholangitis. The model is established by performing a surgery to ligate the common bioduct. This model is rapid and can be completed in 2 to 4 weeks for the in-life study. And available endpoints are similar with that of CCL4 model. As shown in the schematic diagram, the BDL surgery induces an acute hepatocyte injury and proliferation, followed by inflammation at portal area with recruited neutrophils, lymphocytes, and Kupffer cells. Cholangiocellular proliferation persists after the acute liver injury, and fibrosis development will follow. In mouse, the intensity of fibrosis will generally remain the same after 14 days. And JennScript has developed the BDL-induced model in both mouse and rat. In mouse, the model shows a transient but dramatic increase in ALT and AST level in a couple of days after the surgery, and a return to near normal level at day 14 post-surgery at the end of the study. A serious red shows the model is already established 2 weeks post-surgery with no significant increase in fibrosis after that. And one disadvantage of the BDO model in mouse is that animal mortality is quite high. And GenScript has optimized the method for mouse BDO model to control animal mortality. In rat model, animals tolerate the surgery much better and have very limited mortality. Serum, ALT, AST, and total bilirubin level have a transient increase at the acute injury phase and return to normal at the end of the study, as shown in the figures. Histological analysis indicates significant cholangiocellular proliferation, immune infiltration, and fibrosis in portal area at day 14. At day 28, fibrosis development is very prominent all over the liver tissue. Hydroxyproline content is highly elevated at day 28. The biochemical and histological evaluation demonstrates successful developed BDO-induced liver fibrosis model in mouse and rats. So among various models for renal interstitial fibrosis, the UUO-induced model is the most stably repeated and most accepted. And GenScript also provides UUO-induced renal fibrosis model in mouse and rat. To set up the model, a surgery is conducted to ligate the ureter of left kidney, while the contralateral kidney can be used as a control. The surgery induces chronic epithelial injury, inflammation, and tubular interstitial fibrosis in left kidney. After UUO surgery, renal wet weight to body weight ratio, as well as hydroxyproline content in renal cortex, they both increase with time. Elevated level of blood urea nitrogen and serum creatinine suggests impaired renal function. Serious red staining also is adopted to visualize the progressive increase of connective tissue in the kidney interstitium, as we can see in the figures shown in the slide. And we treated the model animals with pirfenidone since day 7 post-surgery. At 4 weeks, UUO model animals exhibited significant structure change in the kidney, fibrotic tissue deposition, and immune infiltration. Pirfenidone treatment inhibited all these changes, as we've seen in panel A. And quantified serous red plus positive staining area and hydroxyproline contents both demonstrated significant suppression of fibrogenesis by pirfenidone. So pirfenidone ameliorates the renal fibrosis induced by UUO. So the last model we will introduce is the bleomycin-induced lung fibrosis model in mouse. This model can be induced by either intratracheal instillation of bleomycin or systemic injection of bleomycin. And GenScript currently provides the former one, which develops faster. Intratracheal instillation of bleomycin induces lung epithelial injury, inflammation, and fibrosis. And other than available endpoints shared by other fibrosis models, bronchoalveolar lavage fluid cell counts, or BALF cell counts, and Ashcroft score can be assessed for lung fibrosis model. As shown in the images, at day 3 after intratracheal instillation of bleomycin, there is a dose-dependent infiltration of inflammatory cells in the lungs and thickening of alveolar wall septa, and showing an acute inflammation phase. And GenScript has optimized the dose of bleomycin so the lung fibrosis model can be successfully induced without significant animal mortality. The model induces animal body weight loss due to inflammation and impaired respiratory function, which is similar with IPF patients. Elevated BALF cell counts suggest inflammation in the lung at day 3 after the bleomycin instillation. And lung weight to body weight ratio, hydroxyproline content, and Ashcroft score are all progressively increased along with time, showing a clear disease progression. And the data, the above data, are supported by HE staining and Mason's trichrome staining results, showing increased fibrotic deposition and immune infiltration. And all these data demonstrate successful lung fibrosis model development. So as the concluding remarks for today's webinar, there is currently huge unmet clinical need for effective and potent therapeutics of fibrotic diseases. So properly established animal models that mimics the disease in human are critical for efficacy evaluation. JennScript has developed multiple fibrotic disease models, and we'll develop more to facilitate drug discovery and development for fibrotic diseases. And track record of our fibrotic disease model services, as well as detailed validation study data, can be obtained by directly contacting us. Okay, so now I would like to hand it over to Maxine.
Thank you very much, Kenneth, for that excellent talk. Before we go into the Q&A session, I would like to introduce our discovery biology services here at JennScript. We offer our customers a seamless experience where we can provide all the services required for the course of lead identification and optimization. We can generate both monoclonal and single-domain antibody leads and test for functional activity in vitro and in vivo. To highlight some of our key offerings, JennScript's antibody and protein engineering services include generating single-domain antibodies, where we are the only CRO to offer this as a service. We are also capable of downstream engineering, such as antibody sequencing, affinity maturation, and humanization. Our humanization service guarantees the affinity to be equal or better than that of the parental antibody. In vitro pharmacology services offer full cell line engineering capability, where we can generate custom stable cell lines with our lentiviral-based cell power platform. We have an outstanding track record of generating stable cells for difficult-to-express transmembrane proteins, such as ion channels and GPCRs. We also provide CRISPR-Cas9-based knockout or knock-in cell line development and provide cell-based assays and ion channel and GPCR assays for functional testing of these custom cell lines. In addition to the fibrotic disease models that Kenneth just talked about, JennScript's in vivo pharmacology services also provide several tumor models, including subcutaneous xenografts, an inexpensive and quick way to test compounds. We also offer orthotopic models, allowing you to study tumors in their specific organ microenvironment. For orthotopic models, we also offer the ability to perform bioluminescent imaging with our luciferase-tagged tumor cell lines. We also offer syngeneic models for in vivo study of potential immune therapeutics against tumor growth. And with that, let's move on to the Q&A session.
Okay, thank you, Maxine. I'm very glad to take your questions, and we do have some questions already here. So let's see, the first is, how do you quantify the histology, and do you have a fibrosis score? Okay, for this question, let's put into two scenarios. For lung fibrosis, we do have a traditional score system, which is listed can be found in the literature, which is called Ashcroft score, and this score is evaluated manually. So this is Ashcroft score for lung fibrosis. But for the fibrosis in liver, we do have other systems. First, we can also do a manual checking by a certified pathologist, providing a score, but it's not called Ashcroft, of course. And this is the most basic method. And the second type of method for quantification we can do is to use regular bright field images and software for the quantitative analysis. And the most advanced method we can do for liver fibrosis is using whole slide scanning and analysis using the Aperio system from Leica. So this is my answer to the first question. And let's see this second question. What are your serum biochemistry measurements? Okay, so for the serum biochemistry measurements, it really depends on different models. For the models in liver fibrosis, we usually check those biomarkers mostly related to liver function. For example, ALT, AST and ALP for the liver injury, and bilirubin, as we've shown, for liver function. So that's for liver fibrosis. For renal fibrosis, we also shown the case in the slides. We test blood urea nitrogen and serum creatinine, and we can see an impairment of renal function. So that really depends on different models. Okay. So the third question is, are there fibrotic disease models for organ systems other than the ones mentioned? Okay, so actually, yes, fibrosis can occur in many organs, such as skin, heart, bone marrow, etc. And they do have corresponding models established. For example, the subcutaneous injection of bleomycin can induce skin fibrosis, but it takes some time, repeated injection, daily or every other day injection. And subcutaneous injection of isoprenoline can induce cardiac fibrosis, that is via induction of hypertension. Okay. So let's see. Next question is, do you include reference compound in your assessments, or do you need clients to provide the reference? So actually, it really depends. For liver fibrosis, we currently do not have a very nice reference compound that always works in all the checked endpoints. So although we show that pirfenidone can inhibit the fibrosis, we do see an elevation of serum biomarkers of ALT and AST. So in this scenario, I would suggest our clients provide their own reference drug. For those models that we already know a good reference compound, we can suggest our clients to include that. But it's for sure totally up to our clients to make the decision to include that or not, or use their own reference compound. Our service is highly customizable. So the next question is what type of platform do you perform histology analysis? Oh, okay, I think that this question is already answered previously. That's our capability of histology analysis. Okay. The next question is, can antibody therapeutics can be assessed in these models? Okay, so the answer is yes, for sure. This is not a problem. As we've shown in the slides before, antibodies against critical regulatory factors such as TGF-beta, CDGF, SDF1, IL-13, or those chemotactic proteins like MCP1, they have been shown in literatures to inhibit fibrosis in animal models. So definitely, antibodies can be assessed in these models. And okay, the next question is, what about the reversibility of the models? Have you seen how long after induction fibrosis is reversed naturally? Okay, actually, we didn't do that test, the disease reverse naturally in JennScript, but according to the literature report, CCL4-induced liver fibrosis at early phase is reversible, but for BDL model it is not. So that's the difference, also another difference between the two models. And let me see. And what is the, another question, what is the typical route of drug administration for the liver fibrosis model? This is also depends on the nature of the test articles. In our hand, during our services, the mostly tested articles are delivered via oral administration, or oral gavage. But for those protein drugs or antibody drugs, they're mostly delivered via IP or intravenous injection. So, okay, the next question is, let me see. What is the turnaround time for the UUO fibrotic kidney model from start to finish, including histology analysis? Okay. For the model in rat, the in-life experiment takes 4 weeks, as we've shown in the slides. And but we still need some more time to prepare a study protocol to prepare animals for the study. And after the in-life study is, we need some time to do sample analysis, including histological analysis, immunohistochemical staining, and final report drafting. So taking all these parts together, it takes about 10 weeks or so to deliver the final report. And I would like to have the last question, which is how many compounds can be tested at the same time? And what is your capacity? Okay, so I think we can at least run a study with around 100 animals at least in one study. So we usually include 10 animals per group, so that's basically 10 groups, excluding the vehicle control and the normal control. We have at least 8 groups to be tested. So, but I believe our capability is definitely higher than that. That's relatively basic number we can do. Okay, I think that's all for the Q&A section. I'll let Maxine to wrap up the webinar.
Thank you very much, Ken. We would like to thank everyone for taking the time to listen in on this webinar today. We hope that the information presented has been useful to you and that you can apply some of what Dr. Jeong has talked about today in your own fibrotic disease research projects. As mentioned at the beginning of the presentation, this webinar will be archived on our website, and links to resources will be posted after this presentation is over. So please visit our webinar webpage, www.jenscript.com/webinars, and click on the Archive Webinars tab to take advantage of these resources. And also, please take a moment to complete a quick poll right after this webinar to tell us how you like this presentation. Your candid feedback will help us improve our services. Thank you again.